The purpose of the video presentation is to give you a perspective about carotid artery stenting and to explain you the basic steps in the procedure and the critical issues in the stenting procedure. You should also learn how to use the devices such as protection system, carotid artery stent and the closer device. Basically, afterwards you should be well aware of the procedure and to be able to perform it safely. Ultimately, our purpose will be served if you become well aware about safe performance of carotid artery revascularization.
Hello, I am Dr. Vipul Gupta. I am in the Neurointervention Unit at Medanta the Medicity. Today we would like to present you an interesting case of stroke with bilateral severe carotid artery stenosis. Patient is a 57-year-old man with history of diabetes mellitus and pulmonary COX. He presented around a month back with right side hemiparesis and MRI revealed patchy infarctions in left middle cerebral artery territory. A carotid Doppler revealed bilateral severe carotid stenosis and patient was referred to us for further management. We performed a cerebral angiogram which revealed around 80% ulcerated stenosis of left internal carotid artery origin as well as more than 90% stenosis of right internal carotid artery origin. Since as per protocol, we should treat the symptomatic site first, we did carotid artery stenting of left ICA around 2 weeks back, which was successful and uneventful. We always like to stage carotid artery stenting when we have to perform other artery stenosis stenting as well for two reasons. Firstly, if we do bilateral carotid artery stenting simultaneously, it can give rise to hypoperfusion syndrome. Secondly, bilateral carotid artery stenting can lead to excessive baroreceptor stimulation with persistent hypotension and bradycardia. For this reason, we like to give a weak gap between the two procedures. Today, we have performed carotid artery angioplasty and stenting of right ICA. Procedure was again successful and uneventful. And we like to present the video of the procedure so as to give you a perspective of how this procedure is performed. This case is particularly interesting because it was very severe ICA stenosis giving rise to slow flow in the distal carotid artery and which was partially collapsed. Sometimes people diagnose it as a diffuse long segment stenosis, which is not so. And as soon as we have opened up the artery, we can see the whole artery has expanded to a much wider caliber and much better flow, as you will see in the subsequent video.
Patient is a 60-year-old man, known case of pulmonary COX and diabetes mellitus. He had stroke 2 weeks back and he has improved substantially in next 2 weeks. CT scan did not show anything significant. However, in the MRI, we could see multiple small embolic infarcts in left MCA territory. The DSA performed shows severe stenosis of left ICA origin, bilateral severe carotid artery stenosis, right side was most severely stenosed. Left internal carotid artery stenting was performed 2 weeks after the stroke. The procedure was successful. 2 weeks later, we planned for right ICA revascularization. The angiogram reveals that there is very severe subocclusive stenosis of right internal carotid artery with slow flow in right ICA. This procedure was performed under local anesthesia. We always like to have a very close neurological and hemodynamic monitoring during the procedure, and we almost always have a neuroanesthetist in the procedure for the hemodynamic monitoring. Local anesthesia is being given. We have taken a left transfemoral route in the procedure, artery being punctured. We always check for good backflow. And once there is very good backflow, a wire is being placed, in this case a Terumo 035 wire. Small nick being given in the skin adjacent to the puncture so as to place the sheath, and a 8F short sheath was placed and 5000 units of heparin was given. For the guide catheter placement, we always prefer a coaxial system, so a soft tip 5F catheter is being used along with the 8F guiding catheter. We think it improves the safety and the ease of placing the guiding catheter. Fluoroscopy is always used for manipulation in the thoracic aorta and the arch of aorta. So you can see soft tip catheter we are trying to place, but you can see there is significant ectasia and tortuosity, and the wire is not able to support the diagnostic catheter. To take the wire up, it can be dangerous because of the underlying stenosis. So we have taken a road map in both the planes so that we can place the wire in road map guidance into the external carotid artery. The road map helps to do it very safely without disturbing the plaque. So you see very carefully the wire is being manipulated into the common carotid artery and then into the external carotid artery. Once the wire is in external carotid artery, it gives enough support to place the 5F soft tip catheter into the common carotid artery, and then it is relatively easy and safe to place the guide catheter into the appropriate position. You should realize there are always plaques in this patient, in the aorta and even the excess arteries. So the use of coaxial system, it prevents any embolism during the guide catheter or a long sheath placement. Guide catheter is in place. And then the diagnostic catheter wire were taken out and a diagnostic run is performed. Shows a very severe stenosis. Intracranial angiogram is always performed before the procedure so that we can compare it from post-stenting angiogram. So the plan in this case is to place a protection device which will be followed by a pre-stenting angioplasty using a 2.5 mm diameter balloon, and this will be followed by stent placement, and if need be we will be doing post-stent angioplasty as well, followed by removal of the filter device. Now this is the balloon being prepared, being flushed. So we always keep everything ready when we start with the main procedure. The filter device is being taken. Preparation of the filter device. HEP saline is being used to fill the pot in the tray. Then the syringe which is given along with the device is being used to flush the filter and the catheter. What one can see here, saline dripping through the proximal port. The filter is also being flushed carefully, and you observe for any residual air bubbles in the filter. After flushing, the topper is tightened on the wire so as to withdraw the filter into the delivery catheter. Now the wire is withdrawn, the filter comes back into the delivery catheter, the golden tip marker perfectly aligns with the catheter. Now both the wire and the catheter held together and removed. Wire was given a very gentle curve so that we can cross the stenosis. A very sharp curve will not help us here. Using an introducer, we are placing the filter device into the guide catheter, introducer being removed. There is a constant flush going through the guide catheter in the procedure. Now very carefully the wire is being taken across the stenosis. You see it passes very freely and easily. Gentle curve has helped us. Is being taken into the upper part of cervical IC up to the petrous IC. Once the wire is distal, well placed, now the wire is being kept stable and slowly we are sliding the filter device which is crossing the stenosis, and we will place it in the upper cervical ICA in a relatively straight segment of the artery. This helps in preventing any spasm or injury to the parent vessel. After this, releasing the filter device is a simple step. The lock is being removed and pulling the white handle, and the filter gets released. Once the filter is released and we have taken out its catheter, we take a run to see the flow in the internal carotid artery. Sometimes in very severe stenosis, just placing the wire occludes the artery here, but we still can see good flow. Now the pre-stenting angioplasty balloon is being taken and prepared. The balloon is in place and it is being prepared, being made air free. We do this step after getting the balloon in position. So your staff should be very ready and prompt at this point. The inflation is being performed and you can see using our two hands we try to keep the balloon stable at the site of the stenosis. So balloon inflation done under fluoroscopy. You can see the balloon expanding. Now after this procedure, this step, stent placement is to be done. The stent device will show you the steps in preparation of the stent. This is a very small needle will come with the stent. So very carefully the stent is removed and then we'll flush the distal end of the stent using this very small needle which comes with the device. So hypernice line is used and very carefully it is being flushed, and once you can see from this proximal port water saline dripping out, we know it is done. Now the stent being introduced into the guiding catheter. At all times we take care to keep the filter wire stable. So stent placement is done under fluoroscopy. In this case, because of the tortuosity, there was some resistance in passing the stent through the arch. At all times care is being taken to keep the filter wire very stable. After some gentle manipulation, the stent passes through. and here you can see stent coming out of the guiding catheter. We are using vertebral body as landmarks to know where the location of the stenosis. You can see the stent being taken across the stenosis. It passes quite freely. We take an injection to confirm the exact positioning. It shows the stent is across the stenosis. You can see the internal carotid artery is almost completely occluded because of the stent delivery system. Now the stent will be delivered. The exact stent is quite easy to deliver and you can deliver it with very high precision. By clockwise rotation, the stent is released and one can usually release it exactly where one wants to. It doesn't jump. Now the stent delivery catheter will be taken out. Again, at all times the wire is kept in a position. Post-stenting angiogram being done, which reveals very good flow in the internal carotid artery, but there is still significant residual stenosis, so we have decided to perform an angioplasty. So the post-dilatation was performed using a 4 mm diameter balloon, 20 mm long. Balloon being introduced into the guiding catheter. Here you can see the balloon in the stent. Now it is in the right position. It is fixed. Again, as we have shown previously, balloon being prepared, being made air free. Just before balloon dilatation, we always warn our anesthetist that when the balloon is inflated, there may be a baro response with a drop in the heart rate and the blood pressure. Here you can see now balloon position prepared. A quick dilatation is always preferable, followed by deflation. Patient heart rate and blood pressure monitored very carefully during this step. You can see the stent expanding, balloon deflated, and now we'll remove the balloon. Now angiogram shows now very good opening of the stent. Internal carotid artery is expanding and flowing very well. There is no evidence of any clot or dissection. Through the retriever catheter, the protection device is being removed. Okay, the cerebral angiogram being performed, which shows much improved flow now and all the arteries are patent. We have removed the guiding catheter and now we'll remove the sheath and using a closure device, the per close system. This is the Markle lumen being flushed. And over a Terumo wire, this device is taken into the parent vessel. When the device is in position, the wire is removed. It is taken into the artery at an angle of 45 degrees and we look for backflow through the Markle lumen. And the foot is deployed, withdrawn slightly, and then the needle is being deployed, and then the suture is being retrieved. The suture is cut, then the foot is being parked, and then very carefully one withdraws the device, and when the sutures, one can see the sutures are separated from the device. Then very carefully the suture is kept taut while the device is withdrawn so as to form and advance the knot. Then using the knot pusher, the knot is being pushed against the artery. Again, the angle is very important. And once the knot is pushed and tightened, then the same device is used to trim the sutures. It is being checked for any bleeding, and now the same device is being used to trim the sutures. These images shows the basic steps of the procedure of protection device placement, stent placement, and the final result after the post-stenting angioplasty. We always perform an intracranial angiogram after the procedure, which shows improvement in the flow in the intracranial vasculature.
Procedure has gone quite well with no major hiccups. Patient is quite alright. There is no fresh neurological issues. In fact, his blood pressure and heart rate have also been quite stable. We did not give any drugs for it. We haven't used any atropine in the procedure. We have closed the puncture site with a suture-mediated closure system or closed proglide, in which a suture is placed at the arteriotomy site, and it has gone quite well, and patient can be mobilized in a couple of hours. We are going to observe the patient for a day overnight in our neurosurgery ICU, mainly for hemodynamic issues, and maybe tomorrow, day after tomorrow, we'll discharge him. He has been on double antiplatelet therapy for last 1 month, which will continue for at least a year. After 1 year, we'll stop the clopidogrel and continue with ecosprin for life. And of course, in this period, we are planning to manage his medical risk factors as aggressively as it can be. After 6 months, we'll perform a carotid artery Doppler to look at the stents and the flow through them and for any recurrent stenosis. I hope you find this useful in your daily practice. Thank you.
How do we reduce the risk during carotid artery stenting? I personally feel training is very important in the basic steps of the procedure, in using the various devices and taking care to avoid complications in stenting. We always prefer to have double antiplatelet therapy for at least 3 to 7 days before the procedure. I feel coaxial placement of a long sheath over a long diagnostic catheter makes the procedure safer. We usually prefer to use closed cell stents along with a protection device. Neurological and hemodynamic monitoring during the procedure is very important. We always like to do a repeat angiogram after 10 to 15 minutes for any clot formation. Intracranial angiogram should always be performed before and after the procedure to monitor intracranial hemodynamics and to detect any embolism.